I'm sure that there are many questions and remarks from the audience, so I'll be brief in few comments. First of all, it's important to challenge accepted concepts in medicine. It's very important to challenge the scientific community with new concepts, because new concepts bring or drive development of new therapies. So it's important to think out of the box and provide evidence for new concepts. This is specifically important in disease like MS, where we have a number of treatments, as discussed, but still there is no cure, and there is lack of information about many, many aspects. So any new concept that is validated is very important. As we have already discussed, in addition to the theoretical aspects, Dr. Zamboni and his team provided some suggestions for diagnostic tools as well as for therapeutic interventions. And these clearly provided or brought a lot of hope in many patients, in many physicians. However, many physicians think that this is yet not mature and maybe even non-responsible. So I would like to touch upon a number of aspects, a number of questions, open questions, and maybe towards a further discussion. First of all, as mentioned already by Professor Stuv, there are open questions regarding the issues of how can SSVI explain a number of clinical, immunological, pathological, genetic, MRI, and many aspects that for many years has been established. That to touch again, how can a single stenosis in the internal jugular or azygote can explain different presentation between patients, and much more than that, different presentations or different relapse in the same individual. As mentioned, spinal or optic neuritis on one side and then in the other side and so on. How can it explain differences in response to therapy? How can it explain what we know today about the effect of viruses, vitamin D, and so on? How can it explain MS in children? You would expect that stenosis would aggravate with age. So we don't see more activated disease with age, and how can you explain it in children? So there are many open aspects or questions from the clinical point of view. There are also questions from the immunological point of view. How can SSVI explain oligoclonal bands? How can it explain all what we know about immune dysregulation in multiple sclerosis? From the pathological point of view, the issue of iron deposit in the brain has been demonstrated by a number of groups, Massimo Filippi in Italy and Grossman in Detroit and others. So there's more and more evidence about the role of iron in the brain. Is it singly or specifically related to CCSVI? How is it related to neurodegeneration? There are many open questions, but is it really related to CCSVI? It's an open question. So beyond this, as mentioned already by Ulf, the questions we have in medicine, many examples of reduced vascular flow, like central vein stenosis or chronic pulmonary diseases and so on, but we don't see MS in these cases. More than that, increased cerebral pressure that should be part of the story, part of the feature, is not seen. We don't see so much headaches, nausea, vomiting in our patients. So how can we explain these aspects? And a point that was mentioned already, if there is, in some cases, or this issue of CSSVI, is it really primary, causative, or is it secondary? This is very important because when we think of intervention or treatment, are we going to treat the cause, or is it a bystander effect? Now, beyond these issues, there is a theoretical aspect. There are practical aspects. As already mentioned, Dr. Zamboni and his team demonstrated and suggested that this can be, in 100% of the patients, an important diagnostic tool. So how can we really explain the differences and the fact that in many groups, this either has not confirmed completely or in very few cases? We would like to have a diagnostic or biomarker that is validated, and it's not either technological dependent or investigator dependent. So we would like to have it in different centers. Why isn't it so? It's a big question. And last, if we accept this issue, or is suggested, let's say if suggested as by Dr. Zamboni, that is beyond diagnostic tool, it can be an optional diagnostic strategy, I would like just to provide my own feeling is that it's important to have a thorough discussion of this issue. It's very important to have a conduction of very thorough clinical trials which should validate these aspects before we suggest our patients to go to this aspect of invasive. It's an invasive endovascular procedure which has its own risk. So I think we should be open for new concept, but before we recommend something, a strategy which carries some risk, the question is how and should we validate this issue. So just to be brief, and I would like to open this for further discussion.
Now we can proceed with this discussion.
So there is no discussion about treatment. I want to discuss about the theoretical basis. And I thank Dr. Stu for the big assist. Your discussion is a big assist for me because permit me to clarify a lot of issues. Pathology of the vein wall. We are submitting a paper resulting in a marker in the jugular venous wall of CCSVI that present a big amount of type 3 collagen respect to type 1, a different disposition of the smooth muscle cells that are in the adventitia rather than in the media, and no evidence at all of T cells infiltration. So these are very important pathological remark that will be published along the next year. Vitamin D. Vitamin D present really convincing element that play a positive role in MS. But the evidence, the level of evidence looking at the paper is not so strong through immunological mechanism. Otherwise, if you should take a look to vitamin D in vascular literature, you find a river of paper showing you that vitamin D is a fantastic protective mechanism for the endothelial cells. So really play a role in stabilize the BBB. Regarding pregnancy open a lot of shunt that download the spinal cord. This is very well known. Regarding geography, I think that all the epidemiological study on MS actually present are a level E of evidence from the epidemiological point of view regarding the number of patients that are examined in the different region. There is a very amount of work to do also from an epidemiological point of view, because are not enough. Regarding optic neuritis, what is the more obvious window to download the amount of blood at the intracranial level? It is the orbit. And we found a lot of bidirectional flow at the level of a cavernous sinus in the patients with optic neuritis symptoms at onset. And we'll publish a paper about this very shortly. Regarding therapy, yes, therapy works, but therapy is addressed to just one of the factors of a very complex puzzle. Why do you not consider to improve the chance to a patient by adding a new tool in your armamentarium after proper randomized control trial? You cannot refuse this without any experiment. And regarding 100%, I was visited by hundreds of colleagues from all over the world. And the angiogram of the 65 consecutive patients showing not just one, no, never just one point of stenosis, but 2, 3, 4 points of stenosis at the extracranial level are fully available for everybody. All the colleagues who visited me may visit the experiment and the angiogram because we are in a teaching hospital and all this material is public. So I do not have any difficulty. If someone should visit us, I may show the 65 consecutive 100% patients with stenosis that we observe. I have no problem. The material is public, and I invite you to come and to see, because our radiologist. Thank you very much.
Any new question?
Professor Zamboni, I think I've asked you this before, and I'm still waiting for the answer. You've performed venograms on these patients and shown the abnormalities. Without having intervened in those abnormalities, when you repeat the venograms over time, do you consistently see the exact same pathology that you see on the first time? And the second question is, how do you explain the difference in gender effect that we see in MS? Why are there so many more females that have this? Are many more females prone to CCSVI?
Really, regarding the second question, Dr. Friedman, I do not have any answer. What I can say you is that the epidemiological data regarding venous disease and chronic venous disease in general, not regarding to the cerebrospinal venous system, consistently show that the female is stricken twice respect to the male. And to the contrary, when you consider, for example, lesion like venous leg ulcer, there is no difference between male and female. However, in the development of chronic venous disease in general, the female show a consistent, significant major epidemiology. Regarding the angiogram, we found at the recontrol a different aspect. Sometimes there was an ineffective treatment. So we found exactly the same picture. For example, if you should have a very long septum, probably this cannot be managed by means of balloon angioplasty, and we observed again the same picture. Otherwise, we found restenosis due probably to an excessive cicatricial response in the venous wall. And this is probably due to the different component, molecular component of the venous wall in course of CCSVI respect to a normal jugular wall. Because there is a big amount of type 3 collagen that is a type of collagen, you know, that is more employed in a reparative process
Yeah, so these are a few cases, but in order to establish that this is a fixed anatomical problem, you would have to show over time that you are, with your Doppler studies, seeing exactly the same phenomenon in the same patient repeatedly over time, or with venography and repeatedly over time without doing anything to the vessel. Then that would make it more believable that this is a problem that is consistent in these individuals. But if you only investigate them once and then you treat them, we'll never know.
Yes, I respect your position. It is right. Unfortunately, at the moment, I do not have longitudinal data, but I may collect this because I have more than 1,000 people scanned, and I operated just 65. So the 900 cohort will be regularly followed up, but at the moment I do not have this data, but you are right. This is very interesting suggestion. I thank you.
I want also to ask how you can explain the gap between your center and Buffalo Center and between very experienced in venous system examination center, for example, Valdueza, who recently published in Annals of Neurology. Valdueza cannot find any CSVI according to your criteria.
Okay, we stop only just for one moment. The same group, with different order of comparison of the author, published 10 years ago a paper on the same methodology, Doppler methodology, on normal subject. And they found, on average, an outflow from the brain of 910 milliliters per minute. That is right, because we have 1 liter any minutes to supply our cells with oxygen. And so it's right that you have 910. The control group this time showed an outflow of 520. So 40% difference in normal controls regarding the venous outflow. So I fear for the deterioration of young German people in 1 decade, because the outflow passed from 900 to 500.
But it can
So
be dependent on
this
device.
means, I do not know, this means that your Doppler methodology does not have the necessary accuracy, because if you have more than 40% difference in normal controls, but this is not established by me. This is very well established in the only document regarding venous Doppler investigation that was published on circulation, that clearly state that no Doppler venous volume measurement over time is considered accuracy. And I demonstrate to you why. Because you need 3 minutes for the jugular on the right in standing, other 3 minutes for the contralateral. You put your patient lying down, and you have more 3 minutes, 3 minutes. So 1 beat cardiac cycle and 10 minutes for the evaluation cannot be considered good vascular lab methods. Okay? So it's inadequate. Second paper, published by a Swedish group, is a very nice paper by using MRI. But you know very well that there is a postural regulation that cannot be assessed by MRI because your patient is not standing in the MRI equipment. It is not possible to have a thoracic pump. So our inadequate system for measuring the physiology of cerebral venous return. Inadequate, nothing more.
Okay. Only 2 questions more, and then we have to end.
My name is Hirsch from Australia, where in fact the epidemiological change from north to south is extremely well worked out and I think extremely accurate and positive, but that's not related directly. Is there any evidence in experimental EAN that superadding the stress, as it were, of obstructing partially venous drainage from the brain has any effect at all, clinically or histologically?
Unfortunately, there is, to my knowledge, there is no an experiment like this. But I want to say you that in 1937, Putnam in Harvard, Boston, ligated vein in a canine model. And after 3 months at sacrifice, nothing of interest happened. At 6 months, nothing of interest happened. But at 9 months, all the dogs developed multiple sclerosis. And this is published in the Archive of Neurology and Psychiatry in 1937.
I will make it very short because we're running late. First of all, you're using, for many times, you're using pathology as a very strong part of your evidence. I wasn't really fully, completely convinced by the pathology and the differences between the various groups. And then my question to you is, you have a very big difference between the secondary progressive and the remitting relapsing group, which may mean that what you are looking at has to do with the remyelination process. So you may be looking at differences in the tissue and in the brain between the demyelination and the remyelination. Can you please elaborate on that?
This is a fantastic question, but unfortunately, I do not have a study like this. This is a dream for me now. I do not have data. Sorry.
Thank you.
Thank you.
I